So if a clavicle fracture comes, a mid-shaft clavicle fracture is a conservative, is a controversial topic. It happens due to the trauma. Mechanism of injury is important, history is important, further examination of the patient to check for the skin tenting and or neurovascular assessment should be done. Regarding known to be quoted is that a female, elderly, and more than 100% of displacement or 2 centimeter of shortening as per Hill et al. GBGS 1997 increases the risk of non-union. Jarvis et al. Quoted in 2017 that the smoking is the most important factor to improve to go towards non-union. A COTS trial was Canadian Orthopaedic Trauma Society trial was done in 2017, which showed more than 2 centimeter of displacement needs operative intervention. Non-union rate or non-union is 2% in ORIF compared to the conservative management, which is 7%. Union rate is achieved within 16 weeks with ORIF, then 28 weeks in conservative management. Later on, Mickey 2012 et al. Showed that non-union rate is almost 14.5% in non-operative, while it is 1.5% in surgical group. But only 8.5% of non-union are symptomatic. So half of the non-unions are symptomatic. A UK clavicle trial in 2017 was done, and it was a multi-center RCT, and a non-union at 9 months, 11% in non-operative group, and only 1% of them, ORIF group, had non-union. A dash and Costner score were higher in operative groups. What nowadays we do is by Robinson and McQueen 2004 study. It shows that the prevalence of non-union at 24 weeks is 6%. So a plan of management should be that if I have a mid-shaft clavicle fracture which is displaced more than 2 centimeter and shortening, I plan to have a 2 radiograph assessment in 6 weeks apart. If there is no progress in the if there is no progress towards healing, I would plan for operative intervention. But I will not do any operative intervention if the patient is asymptomatic. If symptomatic, within 6 weeks, I will go take down the non-union, and if there is any callus formation, I will remove it and to prevent neurological injury, and I will reduce and put a plate. Regarding the surgical technique, I will place the patient in beach chair position, head tilt away from the ring. DHS drapes can be used. Curved line and incision parallel to the skin creases, inferior to the clavicle incision is possible. I will carefully divide platysma, exposed periosteum. Trapezius is superior and pectoralis major is inferior. Trapezius supplied by accessory nerve and pectoralis major supplied by lateral and medial pectoral nerve. Clavicle synthesis place will be applied. Vessel lie posterior to the clavicle medially and inferior to the clavicle in mid and lateral 1/3 and put a pre-controlled plate.